Number 12, typical exam case, maturation attack during urination. What do you mean by maturation attack? Patient will start getting headache, pounding sensation, anxiety, sweating, syncope during maturation. And when you take the biopsy from the bladder, this is normal urothelium, and in the lamina propria, you can see nests of cells. See, remember I told you when we talked about a nested variant of urothelial carcinoma, paraganglioma is one of the differential diagnoses, and this is paraganglioma, and this history helps you to diagnose that. And when you do markers, remember GATA3 I told it's a neuroendocrine marker, and synaptophysin also neuroendocrine marker. And nested variant, synaptophysin will be negative, whereas GATA3 can be positive because GATA3 is a marker of urothelial epithelium also. So please don't mistake a nested variant of, we cannot call variant now. Variants are only for molecular types. So in histologically, we have to call them as subtypes. The nested subtype of urothelial carcinoma should not be mistaken for paraganglioma. And the last bonus case is the bladder biopsy. You see a lot of calcifications, and if you are lucky, you may be able to see a non-calcified egg of a schistosomiasis. And these are all calcified masses. So please remember, they used to say this is very common in Egypt because of global tourism. They are seen very commonly in our part of the world also. So this is schistosomiasis. Coming to IHCs in urothelial tumors or in bladder. So these are all the IHCs. To make sure it's epithelium of bladder origin, it's GATA3, CK7 and CK20. But this bladder origin may not differentiate low-grade papillary urothelial carcinoma from high-grade because they are all of bladder origin. But when you are thinking of urothelial or non-urothelial, for example, paraganglioma, these can be of use. And this we already talked about. To differentiate reactive from dysplasia, CK20, Ki67, P53. And remember, we talked about muscle invasion. How do you know it is a muscularis propria? Because you can see wisp of smooth muscles around big blood vessels in the lamina propria. And there is a marker called smooth-lane. And this smooth-lane is positive only in the muscularis propria. But many people are questioning its reliability. But whenever you have a question whether it is muscularis propria or muscle bundle next to blood vessels, attempt this marker smoothly. Nephrogenic metaplasia, we already showed you PAX8 positive for nephrogenic metaplasia. And whenever you see tumor with a lot of lymphoplasmacytic cell, you have to do IHC for PD1 and PDL1. So these are all the main markers for epithelial lesions of the bladder. I never touched upon the spindle cell lesions because then it can be leiomyosarcoma, rhabdomyosarcoma, fibrosarcoma, or postoperative spindle cell nodule. A lot of markers in spindle cell, but these are all the IHC markers in common urothelial lesions. Molecular features. So we all know normal urothelium, they undergo hyperplasia and dysplasia, become non-invasive, which is low grade and high grade and carcinoma in situ. Then it will become muscle invasive. So what are all the markers for low grade? It FGFR. As they progress from low grade to invasive component, they keep accumulating the molecular events. TP53 and RB gene, they are very bad for carcinoma in situ or muscle invasive. And like in breast, before that, take a picture of this. Like in breast, now we have the molecular classification of urothelial carcinoma. It is mainly luminal, stroma rich, base is squamous, and neuroendocrine-like. In the luminal, it is papillary, luminal non-specific, luminal unstable. And stroma rich are also known as inflammatory rich. Take a picture of this, and these are all the markers or molecular markers to type these tumors, but I don't want to go into them. I just want to highlight molecular classification of bladder cancer, they may ask you in the exam. It's luminal, stroma rich, basal or squamous, base is squamous, neuroendocrine. Like in the luminal type, there are three subtypes: luminal, papillary, luminal non-specific, and luminal unstable. Why we have to know that? Lot of treatment differences depending upon the molecular markers. That's why we have to know the molecular features. I think that brings the end of our discussion, and I hope you are all ready for the post test. Before going into the post test, madam, any questions, madam?
Yes, sir. I'll be seeing. No questions in the chat box, sir, so far. I think
Super.
your presentation will be very clear so that they would understand everything, sir. Now there will be any queries from the audience. Can you put in the chat box or directly you can ask, sir?
Yeah, have you unmuted their mics, madam? We can do it at the end. I will
Yeah.
just go through the post test.
Yes, sir.
So same 7 questions. I hope you can do better now. Normal mucosa, the following cell can show ATPR. The answer is umbrella cells. Neutrophils and lymphocytes are commonly seen infiltrating the bladder mucosa in reactive ATPR. Very frequent mitosis is seen in papilloma, punlump, low-grade, high-grade papillary urothelial carcinoma. The answer is high-grade urothelial carcinoma. This is more theoretical question. Urinary bladder can be caused by all of them, all of the above. In the last question, lymphovascular invasion high in the following, I should not call it variant, in the following subtype of bladder cancer. And I will correct it just now. Otherwise, I will forget. Subtype. Sometimes it's very difficult to unlearn and relearn. So lymphovascular invasion is high in the following subtype of bladder carcinoma: squamous, micropapillary, adeno, and plasmacytoid, and micropapillary carcinoma. I hope you all got the answers right in the post test. So conclusion. There are 14 important lesions you have to know in the bladder, especially in the exam. I just went through all of these cases. I covered most of them. So you can take a picture of this, and these are all the tumors or lesions they may show in the exam also. So if you know these cases, you should not be worrying about bladder lesions. And how will you approach? There are mainly 6 papillary lesions and 4 flat lesions you have to remember. Papilloma, punlump, low-grade non-invasive, high-grade non-invasive. When it is invasive, it is a T1 cancer, lamina propria invasion. When T2 cancer, when muscularis propria invasion. So when you see bladder lesion, is that papillary or non-papillary? When it is non-papillary, it is flat lesion. We have 4 members: AUP, AUS, dysplasia, and carcinoma inside. When you see papillae, then you have to look for cytological atypia. When there is no cytological atypia, it is papilloma. When the cytological atypia is present and minimal, lamp, mild to moderate or mild, low grade, and when it is moderate to severe, it is high grade, papillary, non-invasive papillary urothelial carcinoma. When there is cytological atypia, you have to ask for invasion. And in these papilloma, punlump, and low grade and high grade non-invasive, there won't be any invasion. And when there is invasion, you have to see whether it is in the lamina propria, then it will become T1 cancer. And is the invasion involves into muscularis propria, then it will be T2 cancer. So this is the easiest way to approach any bladder lesion. And what are all the things you have to mention in the report? In TURBT, you have to mention the histological type, grade, tumor configuration, whether it is papillary, solid, is there muscularis propria present, and if it is present, is it invaded by the tumor? and additional pathological findings, carcinoma in situ, dysplasia, inflammation, or therapy-related changes. In the cystectomy, in addition to that, you have to talk about the margins and direct extension to the adjacent structures. So these are all the points you have to mention in the pathology report of a bladder cancer. These are my beautiful references, pathologyoutlines.com. And this is the Blue Book, Bible for Us, WHO Blue Book, 5th edition in 2022. And these are the articles. What's new in WHO 5th edition urinary tract from Histopathology 2022. Molecular subtypes of bladder cancer in advances in anatomic pathology, May 24. This is a very recent one. And then the last is best practice recommendation, immunohistochemistry. Even though it is old, it is gold. I think you all remember the simple person from Turkey. He just came simply and got the gold medal. So this is like diagnosing only with IHC. And this man is heavily equipped with all modern things. And this is like IHC, molecular, and expert consultation. You start with this person, and if it is you are not able to get the diagnosis, go to this person. And thanks a lot. Have a great day.